Hi everyone. I want to thank you for your time and looking over this presentation and helping me with my project. It's exciting and could really tee a lot of you up for a DNP project of your own if you so wanted. So hopefully you will find this interesting and you will learn something, and I really appreciate your help. Here we go. There is a known association between stroke and depression. This was first identified in controlled studies in the 1970s, but has actually been recognized as an association for well over a century. A review of meta-analyses find that about 30% of patients develop depression at least at some point in the 5 years following diagnosis. The phenomenon is not entirely understood, but it is believed to be associated with vascular depression and chronic small vessel ischemia, suggesting that an ischemic event can create a cascade of brain changes. These changes follow the same pathophysiology as a slowly developing vascular depression, but do so acutely following the ischemic event. Depression is not an unexpected sequela of any disabling illness. However, studies that compare depression in stroke patients and similarly disabled orthopedic patients have found depression more prevalent within the stroke population. While the timing of post-stroke depression isn't completely clear, the most severe depression is correlated within the first year of recovery. Depression following stroke is related to poorer recovery and increased risk for stroke recurrence. Despite the obvious impact of depression following stroke, it does remain underdiagnosed. The reasons for this are complex, and I hope that we will explore these further during this presentation. Few studies have looked at risk factors associated with post-stroke depression, or PSD. Certain genetic variations have been identified, including increased methylation status in certain genotypes and higher levels of brain-derived neurotrophic factor, BDNF, in groups with more prevalent and severe post-stroke depression. Gender has been identified inconsistently as a risk factor, noting that women were more likely to suffer from PSD. Not surprisingly, a personal history of anxiety and depression was highly correlated, as was a family history of depression. Also, not surprisingly, the more severe the stroke, the higher the incidence of PSD. What is surprising is that depression following stroke was not always associated with the type of stroke, ischemic versus hemorrhagic, or the etiology of the stroke, meaning large vessel occlusion based on embolus or other type of ischemia. The lesion location has been studied extensively. Left frontal and left basal ganglia strokes have been most strongly associated with depression, although within the first 2 to 6 months. Follow-up studies have not supported lesion location as a consistent predictor for depression, and so research looking at this is ongoing. Finally, a lack of social support, although not marital status or living situation, was also identified as a predictor of post-stroke depression. Future research continues to look at changes in gray matter along with lesion location for MRI results to help better predict patients most at risk for PSD. Post-stroke depression affects about 1/3 of stroke survivors and is associated with an increase in all-cause mortality, fairly dramatically, more frequent subsequent hospitalizations, longer hospital stays, decreased adherence to lifestyle modifications, and their medication regimens, leaving them at risk for recurrent stroke, elevated risk for recurrent stroke. PSD is also associated with poorer quality of life for both patients and their caregivers. Rates of diagnosis of PSD identified in routine practice are at about 5%. This is much lower than that 30% that studies have found looking at screening for PSD, and suggests that many patients with active post-stroke depression remain undiagnosed. As you can see here, the American Stroke Association, as part of the American Heart Association, has had guidelines that recommend routine screening for depression in stroke survivors since way back in 2010, but these still remain inconsistently followed. You may have noticed that the guidelines do not recommend a specific screening tool, nor do they make any recommendations for the timing or frequency of depression screening, and this is likely contributing to the lack of implementation in routine practice. There are several barriers to routine screening for post-stroke depression. The barriers are diverse, but they include the lack of knowledge, busy outpatient office schedules, limited financial and training resources, and probably largely no validated screening tool for specific use with stroke patients. There's also an unclear pathway for those that screen positive for depression, and the concern about the level of evidence for actually the treatment of the depression itself. The circuitous nature of this barrier leading to inaction has resulted in decades of knowledge about the prevalence and significance of post-stroke depression without any significant momentum in the identification and treatment. The goal of our evidence-based practice improvement project will more narrowly focus on the identification of an appropriate screening tool and the implementation of this tool in our practice. The PHQ-9 has been widely used to identify depression in the post-stroke population and has a sensitivity ranging somewhere between 50 to 100%, although the 50% is more of an outlier, and specificity between 63 to 97%, with most studies finding acceptable psychometric properties of greater than 80% sensitivity and specificity. At the Florida Stroke Institute, eCliniWorks is our electronic health record platform, and it has the PHQ-9 built right into the chart as part of the drop-down menu. In addition, the office RNs have been trained using the PHQ-9 for use when they float to our associated psychiatric outpatient clinic. It is important to note that the PHQ-9 does not require any formal training to use and is free of cost. In order to increase screening for PSD and comply with the American Stroke Association guidelines, this project aims to implement a 6-week pilot where our office RN will ask verbal permission for the patient and then appropriately complete the PHQ-9 on the patients following up in the outpatient stroke clinic. The RN will then verbally relay the results to our office providers and will be part of the patient's chart and available for clinician review. The focus again of this project is to implement screening. As such, treatment of post-stroke depression is outside the parameters of what we're trying to do. However, resources will be available, including the Alachua County 24-hour mental health hotline, and to make sure we have a very clear referral pathway to our affiliated psychiatric group through PSG. Again, thank you very much for your time and attention and your willingness to help me implement this project. And again, hopefully this was something that you found interesting and that you learned something. And I, for one, can't wait to see how this goes and look at our results. Obviously, the aim is to increase our screening, but it will also be interesting to take a look at provider preferences, how the implementation went, and just to kind of look even at the descriptive statistics of the kinds of patients that we see and whether we identify actually more post-stroke depression than using our routine review assistance. Thank you all very much.